Welcome everyone. We know it can be hard to talk about. Maybe you're running to the bathroom a little more now because you can't hold it in. Maybe you're hiding the fact that you have little leaks when you're laughing, coughing, or sneezing. Or maybe sex just isn't as good anymore because it's painful. Sometimes we tell ourselves that's just part of getting old or part of life after a medical condition. Today, we're here to share with you it doesn't have to be that way. You can get your life back. Hurley physical therapist Kacy Houle is certified in pelvic floor function, dysfunction, and treatment. She has her doctorate of physical therapy from University of Michigan Flint, and she's going to show you how you can improve your condition with therapy. If you have any questions for her, you can text them to 248-935-2562. Text, don't call. You can also post questions to Facebook or YouTube. She will be happy to answer them live following her presentation. Glad to have you here, Kacy.
Hi, thanks for having me. So just a little bit of background on myself. So I've been with Hurley for about 9 years now, and I've been working outpatient physical therapy at one of our clinics. Today I want to talk a little bit about some of the more common diagnoses seen with a pelvic disorder, as well as talk more into detail on two of the most common ones I see, being incontinence and pelvic pain. I'd like to kind of talk a little bit about kind of what goes into an evaluation as far as what to expect, how long it takes, and kind of what tests and measures we're looking at. And then talk a little bit about what the treatments look like as far as how long they are and kind of what exercises and things we might be doing. So, for the first kind of diagnoses that we see most often in the clinic, this list does not list all of them, but pelvic floor dysfunction, pelvic pain, incontinence issues, pregnancy and postpartum related issues, be it pelvic pain, back pain, or incontinence. We have prolapse and pelvic organ descent, as well as cysticeals and recticeals that may occur, and then lumbar and SI pain kind of being more of our orthopedic conditions, along with painful sitting. So with the pelvic floor, kind of can be either hyperactive or a little bit underactive, either weakened state or either due to any sort of surgical components. Some of the more hyperactive pelvic floors that we see can lead to more of our painful conditions. So going more into the urinary incontinence aspect, we're looking at a bunch of different patient populations, and here's a few numbers for each of those. Younger women, especially athletes, can definitely report urinary incontinence, about 25% of them. This may be due to their higher impact of sport, also leading into their increased abdominal pressure on their pelvic floor, resulting in some of that leakage and incontinence that they might report. 44 to 57% of middle-aged women and postmenopausal women have reported urinary incontinence. With this, you have more of a hormone aspect also, as well as age. 75% of older women in nursing homes have reported presence of incontinence. Also, with their increased age, could also have effect with some decreased mobility. Maybe they can't get to the bathroom as easily as they were able to when they were younger. Maybe they also have a little bit of pain with it when their joints. And then in males with post-prostatectomy conditions, we can see a very large range of percentage in men. 2.5 to 87% may report some form of urinary incontinence after their surgery. So then we're also looking at three different types of incontinence, be it stress incontinence, kind of referring back to that increased abdominal pressure down on our pelvic floor. An urge incontinence, maybe you have a little bit more increased urgency to get to the bathroom, and it's so much that you can't make it to the bathroom, or a mixture of both. Risk factors that we talked about before was the increased age, history of any type of childbirth, pregnancy, the hormones with the menopause, and some surgical with hysterectomy, and then obesity. There was a recent study done looking at CrossFit women, and they did find that they had an increased prevalence of incontinence, about 32 to 38%, likely as a result of the high level of impact of their sport and their history of childbirth or increased age again. So our other one that we'd like to look at is pelvic pain. So on average, about 1 in 7 American women ages 18 to 15 may report some form of pelvic pain. 90% of those also report pain with intercourse, but 61% have no definitive diagnosis. And this is important because There are many causes that are linked to the increased pelvic pain and chronic pelvic pain, but in some cases nothing can be pinpointed and they aren't quite sure why they're having chronic pain for so long. So some causes that have been kind of linked to pelvic pain: malignancies, so cancer origins, endometriosis, sometimes with the abdominal pain, pelvic inflammatory disease, cystitis, kind of bladder inflammation, and then trigger points found in our musculature above and below and in our pelvic floor, including with low back pain, depression, constipation, and IBS. So there is also a bowel component as well as potentially a urinary component with pelvic pain symptoms. Also, they may report some difficulty in voiding, defecating, limited sitting, even wearing tight clothes may aggravate their pelvic pain. Difficulty sleeping and poor prolonged posture are kind of results of this as well. And it's estimated that worldwide, 26% of women around the world have reported some form of pelvic pain. Treatment is variable as far as success rate due to that unclear diagnoses in some cases, maybe due to a lack of understanding and maybe even lack of testing. So those are the two main types that I typically see in the clinic more commonly. Next up would be an evaluation that would be scheduled once we get the script from your doctor. First off, we typically take a very thorough history. We're going to be looking above and below our pelvis. We're going to look at our posture. We're going to see if there's any pain with any muscles. We're going to check the strength of your muscles, endurance. If there's any compensations, maybe one part of you is weaker than the other, so the stronger section of you has to kind of take up that slack. And so sometimes we have a lot of asymmetry found. We may look at your gait and how you're walking as well. I'd like to also say that internal examinations are sometimes done. They are completely optional, they're never mandatory, and sometimes they can definitely help as far as kind of outlining the plan of care and the treatment that we're looking into. So for an internal examination, usually a visual inspection is completed first. We're looking at any skin issues, maybe any presence of scars, and even if there's a presence of prolapse, sometimes that can also be visible. Trigger points and tenderness can be found in our pelvic floor just like any other muscle. They can have increased tension and they can cause some pain with tension and pain and palpation. We will look at some muscle testing of your pelvic floor as well. And sometimes reflex testing is done just to see if there's any nerve involvement. So once the evaluation is done, typically all the treatments are scheduled after that, and they're about an hour long that you'll be in the clinic for. This is a great range of types of treatment that we might look at doing. First one being therapeutic exercise. Manual therapy may include trigger point release or even cupping. Sometimes that can increase the tissue flexibility, increase some circulation to the area. We have a biofeedback unit which uses surface electrodes to kind of give an indication whether or not our pelvic floor is working properly. For those that learn with a visual aid, this is usually a good option for those. Patient education is very important. Sometimes a bladder and bowel diary is given, so we can kind of see where the patient is doing as far as their habits, when the leakage is occurring, if there is any, and kind of what their daily life is looking like as far as what they're eating, what they're drinking, and when they are using the bathroom. And then from there, we can make any sort of modifications to help retrain their bowel or bladder. Neuromuscular re-education is used usually with our pelvic floor strengthening program. And then again with the postural retraining, looking at how you're holding yourself, be it sitting or standing. And then from there, from the evaluation, the symptoms that we found, the weaknesses that might be there, we treat kind of what we see. We have incorporated yoga poses in the past, and definitely some breathing exercises for those that may have a more hyperactive pelvic floor and more pain. Some exercises I would say for just in general urinary incontinence would be just to get you mobile again, get you out walking, get you on just a routine. Consistency is key for really getting some of these symptoms to decrease or hopefully just go away completely, and to get the quality of life a little bit better. And yeah.
Okay. If you have any questions, text them now to 248-935-2562 or post your questions on Facebook or YouTube. How long does somebody have to go through therapy before you start seeing a difference?
I would say on average, so usually when we schedule out the evaluations and the treatments, we're usually seeing patients about twice a week for on average 4 to 6 weeks. Usually, as long as they're consistent with their exercise program, they're compliant with coming to their appointments, I would say by the 3rd week, they usually will see some sort of marked improvement that they can actually tell, like, oh wait, I did notice that I'm not using the bathroom as much, or I'm not having as many episodes of leakage and things like that. But usually at least 3 weeks of consistent work is what most of the patients start seeing improvement.
Someone is asking if there's things they can do at home. Once you're in physical therapy, are there exercises that you send people home with to do, or after therapy ends, or?
Definitely. So that kind of goes back to the patient education. So typically after your first treatment in the clinic, most of the exercises that we do, we're going to be giving with a handout. Any equipment that you may not have, as far as like a TheraBand, we typically will issue that at the first treatment as well. And then beyond that, we'll progress the exercises once they get a little bit easier and maybe move from a sitting position, lying down position, more to a standing position against gravity, just to make the exercises a little bit more difficult but challenging, but still able to get a little bit more success with increasing some of the strength of our pelvic floor.
Is there a certain age when physical therapy will not work for women?
I don't believe there's any age that it can't work. I've had a wide range of women coming in, be it from kind of adolescence, like teenage years, all the way to women in their 70s and 80s. And most women, especially in our urinary incontinence kind of patient population, most of them have shown a very marked decrease in the episodes that they've noticed, as long as they've kept up with it and have stayed consistent with their exercise program.
I have a couple of patients who have had incontinence for many years. Some of them are trying medicines. They've tried bladder sling. They've tried different things. Where does physical therapy come in the range of possible options? Is it something you do first? Is it something you do after other things don't work?
I like to think of it as kind of a multidisciplinary approach. It's not just one thing that may kind of cure your symptoms. It's going to be the work of a few different things. So I've worked with women that maybe haven't seen physical therapy before. Maybe they have tried the sling, or they've gone to their doctor and have tried medications. But usually kind of a combination of all of them. If the medicines were working a little bit, but not all the way, maybe the sling did help a little bit, but didn't resolve all their symptoms. Usually with physical therapy, in addition to all those other things, they can see a little bit more of an increase in seeing the positive parts of what their symptoms are like going away, and they have noticed some of those better quality of life, like activities that they would be going into.
If incontinence comes on quickly, could it go away on its own too?
I would say it can. Sometimes just time, like maybe they had some sort of incident that triggered their episode of incontinence. Sometimes just time and just regular healing can also have it go away as well.
A couple different people are talking about bowel issues and also incontinence. Are your bowels and bladders tied together at all?
So if we think kind of the anatomy of our pelvic floor, they kind of work as like a hammock for our bowel or bladder, reproductive organs, and kind of our abdominal viscera. So once we help strengthen our pelvic floor, if that's what's needed, it usually will affect in a positive like both bowel and bladder, depending on what the symptoms are and depending on what the evaluation is. Especially with bowel, sometimes that also we would really need to talk about kind of food intake, diet, water intake, as well as kind of habits of daily life, maybe straining with a bowel movement. So there's a few other things that would come to light with the evaluation that we would also talk about to kind of address the bowel issues.
Well, this person's already seeing a urologist, and they say, can can the urologist suggest coming to the clinic?
Yep. So for physical therapy scripts, they can be signed by any physician, physician's assistant, and nurse practitioner. Certified nurse midwives can also sign scripts at Hurley.
So do you have to have a referral, or could you just call the
So
office?
for the evaluation, we wouldn't need necessarily the referral or script, but in order to actually treat you, we would. So sometimes it's a little bit faster if we have the script to set up the evaluation, because sometimes we're able to do treatment the first visit, and then we can schedule you right out. Otherwise, we would have to put your therapy on hold until we would get that script from that physician.
Joanne wants to know if the incontinence she's been experiencing since having a baby might go away on its own, or if she should seek treatment.
I would say it can definitely go away on its own, especially depending on how long it has been postpartum. Usually clearance isn't given until 6 weeks. And then just kind of slowly getting back into your normal routine, any exercises that you had done before, or even starting an exercise regimen, that can definitely help decrease your level of incontinence. And again, it can go away on its own. It's in those cases that it doesn't. Some women will seek out physical therapy or other types of disciplines. PT can help kind of speed that along at times, because we know kind of what exercises to give you, how often you should be doing it, and that sort of thing.
I think you may have addressed this, but PT can work for bowel incontinence and urinary.
Yes, definitely. We have treated both with great success.
Okay, great. Well, looks like that's it. Thank you so much. Good stuff. We hope you got some answers on your concerns. If you're ready to take back control of your pelvic floor, you can call 810-262-2350 or head over to hurleymc.com. As Kacy said, it might be better to get a script first, speed things along for you, so you could go that route too. Thank you to Mid-Michigan Now for being our great broadcast partners. Have a great day, everyone.